Welcome everybody, and thank you for joining this session on COVID-19 and understanding the spread of coronavirus. Today we are discussing some frequently asked questions about COVID-19. This event is brought to you by Punascha, the Bengali Society of Greater St. Louis. Today we have researchers and physicians from Washington University and other hospitals who will be elaborating on the spread of the virus. Your moderators are me, Shirin, and Ankita, rising seniors in Parkway West High School. We would like to ask the audience to turn off your microphones and videos to minimize distractions, and if you have any extra questions, please type them in the chat session. At the end of the presentations, we will ask the panelists to answer them. We will now introduce the panelists and the keynote speaker.
Dr. Bhishan Chakraborty, MD, MP.
Hello.
Hello, I think
on
we
the
lost
podcast.
Ankita.
Yeah, the audio part is missing on Ankita.
I think she froze.
Yeah. So,
Shirin, can you go ahead and maybe
Yeah, for sure.
start introducing everyone? Yeah.
Dr. Bhishan Chakraborty. Bhishan Chakraborty, MD, MPH, is a board-certified physician in internal medicine and works at Amen Nephrology and Hypertension Associates as a nephrologist. He earned his medical degree from JMF Medical College, India. He completed his residency at Advocate, Illinois, Mazarnik Medical Center, Chicago, and his nephrology fellowship at the University of Illinois, Chicago. He also obtained an MPH in epidemiology from the University of North Texas. Dr. Baijanto Maiti. Dr. Maiti graduated from Calcutta Medical College and then did a PhD in human genetics at the University of Utah. He then moved to St. Louis and completed his residency in neurology at Barnes Jewish Hospital, Washington University. He stayed there to do his fellowships in neuromuscular disorders and movement disorders. He is currently an assistant professor of neurology at the Washington University School of Medicine. His clinical practice focuses on patients with Parkinson's disease, dystonia, Huntington's disease, and other movement disorders. His clinical research utilizes functional imaging techniques, including PET and MRI scans, to unravel the pathophysiologic basis of memory loss and balance impairment in Parkinson's disease.
Shirin, you should continue.
Okay. Dr. Shurajit Majumdar. Shurajit Majumdar, MD, FACP, is a board-certified physician in internal medicine at Chesterfield Internal Medicine and Rheumatology. He earned his medical degree from Calcutta Medical College and completed his postgraduate degree in internal medicine at the University of Calcutta Institute of Postgraduate Medical Education and Research. He completed his residency at Barnes Jewish Hospital and his fellowship in medical leadership from the University of South Florida's Leadership Institute. He also obtained the prestigious membership of Royal College of Physicians in 1992 while working as a registrar in medicine in the United Kingdom. And
Dr. Debopriyo De. Dr. Debopriyo De, MD, FACP, is a board-certified physician in internal medicine practicing as an academic hospitalist at SSM St. Mary's Hospital, St. Louis. He is a core faculty member for hospital medicine at the SSM St. Mary's Internal Medicine Residency Program, an assistant professor of medicine at the St. Louis University School of Medicine, and an adjunct assistant professor of medicine at Saba University School of Medicine, Caribbean Islands. Dr. De earned his medical degree from Maulana Azad Medical College, University of Delhi. He completed his internal medicine residency from University of Illinois College of Medicine at Urbana-Champaign. He specializes in the practice of hospital medicine and is involved in the evaluation, diagnosis, and treatment of hospitalized patients. He also participates in the clinical training of internal medicine students at St. Mary's Hospital, medical students from SLU, Saba University, and pharmacy students from SIU at Woodsville, Illinois. Dr. Bishwas. Professor Bishwas is the chairman of the Department of Energy, Environmental, and Chemical Engineering at Washington University in St. Louis. He also serves as an assistant vice chancellor of international programs. He has more than 425 journal publications, has presented several invited presentations nationally and internationally, holds 10 patents, and has spun off 2 startup companies based on his inventions. He has won innumerable awards for his work and is a member of the National Academy of Engineering. He has advised and graduated 56 doctoral students, all of who are accomplished in their careers in academia, government, and industry. Prosim Bishwas received his PhD from the California Institute of Technology, his MS from the University of California, Los Angeles, and his B.Tech degree from the Indian Institute of Technology, Bombay.
Great. Thank you, Ankita and Shirin. I am delighted to be here. I hope everyone can hear me. And if we have some technical problems, it comes with the COVID-19 situation. So just take it as another impact of that and bandwidth constraints. We are delighted to have more than 40 or 45 people listening in, and I hope some others can join in too. I'll request everyone to mute. Feel free to type in your questions as we go along, and you will have a chance to then ask them. The moderators will read it out from the chat box. I am not an expert. Maybe many of you, most of you know more than the subject than I do, but I thought I would take the opportunity to tell you a little about what we are doing at Washington University. While everything is in lockdown, some of our labs are open, working with our colleagues in the School of Medicine. But I'm, of course, delighted to have a very distinguished panel, and any shortcoming that I have in my knowledge and expertise will be made up by this group of experts. And I'm sure you will have your questions answered well and learn something. So we will go on and let me see, there seems to be always some technical issues. Okay, this is the outline of my presentation. It'll be a general presentation. I hope the youth are listening in because it's more targeted to them. I'll first talk about the disease and the virus which causes the disease, and then and a basic understanding, maybe if anything, that I would like to communicate is the importance of a in-depth understanding of the mechanistic details and how that can help in, for example, coming up with a strategy to develop antiviral drugs, vaccines, and so forth, right? And then I want to relate to what we are experiencing today. Monday, Missouri opens up, St. Louis County and St. Louis City will open up. We really need to understand how the virus spreads. I'll focus a little on the airborne transmission route, and then how could we prevent and protect ourselves from this spread. And then, of course, as I indicated, my physician colleagues will be delighted to answer a few questions and so forth. So there are different names that are used. One should also be familiar with terminology. So I thought I would start that way. You have heard of COVID-19. That is the name of the disease, right? So if you say that there's a spread of COVID-19, you're not referring to the spread of the virus, you're referring to the spread of the disease. And it comes from corona, CO from corona, VI from virus, disease from disease, and 19 refers to the year that this virus was sort of detected first, and that we had some epidemiological issues with it. Of course, people know in China. The virus that causes this disease, there's always a cause for a disease, is the severe acute respiratory syndrome coronavirus. That's a rather long name. And you, of course, choose the letters as I have highlighted. Hopefully you can see it on your screen. And it comes out as SARS-CoV-2. It's the novel coronavirus, is again a layperson name given to it, or a short form name that we give to it. So the virus is SARS-CoV-2. The disease is COVID-19. Both are, of course, important. They are interlinked, and we'll try to understand a little more about it in my talk. But I thought I would tell you what are viruses first. They're extremely small entities. You might be inhaling some of these viruses, hopefully not the SARS-CoV-2 virus where you're located, but viruses tend to be in a range of sizes. We encounter them in many places. They are, in contrast to bacteria, much smaller. Bacteria tend to be larger, of 1 to 5 micrometers in size. And just to get a scale, you know, I come from an engineering background. We always try to look at things with a realistic viewpoint. So if you feel hair on your head, I'll just reach out for my hair. That is about 50 micrometers in thickness. It varies, 50 to 100 micrometers. So you can see a bacteria is also quite tiny compared to the thickness of our hair. And a virus is an order of magnitude smaller. 1,000 nanometers make up 1 micrometer. So you can see just on the thickness, the cross section of your hair, I could place maybe 100 of these viral particles, or maybe at least 50 of them if I line them up, right? So this is extremely tiny. Obviously, I can't see them. They contain them. Sometimes the debate, is it a living organism? They do contain key elements of a living organism. And the entity we would be interested in are nucleic acids, the DNA and the RNA. These are typically surrounded by a protein coat. Of course, I want to talk about the SARS-CoV-2. It's about 120 nanometers. There are certain other viruses, for example, the polio virus, that tends to be much more smaller. So in our domain of things, we say that this is a relatively larger viral particle. But the coronavirus has a layer of coatings of a protein, and the internal structure is the RNA, which is the key structure which infects a cell and duplicates inside a cell. And I'll walk you through that. But another key important factor is the spike protein, right? The name corona comes from, of course, the general meaning of the term is crown. It looks like a particle that is decorated with a crown-shaped object. And the spike protein is extremely important from a multitude of different reasons, right? And we will see that. So just remember that the spike protein looks like parts of a crown, and the head of the spike protein is mushroom shaped. And that shape sort of fits into certain enzymes. And these things, you know, the evolution of viruses, that's a whole subject matter by itself. They want to survive. They want to connect to cells, duplicate, and they, of course, also mutate as we go along. But for this particular virus, let's remember that structure. These virus particles, they're typically airborne. I'm just jumping now into, so if I'm symptomatic, which means an individual has the virus and they have some effects or symptoms from the virus, they might be coughing, they might be sneezing, and the coughing and sneezing gives out an aerosol, right? You could also be asymptomatic, and you might have heard these terms, which means I'm not coughing, I'm not sneezing, I'm walking around healthy, I'm not impacted in terms of any negative symptoms of this virus. But I'm talking, I'm breathing, and I might be giving out these viruses, right? So typically it might look something like this. When we talk, we give out an aerosol. An aerosol is nothing but small particles suspended in air, right? And this is concerning because even as I'm talking, I'm giving out this aerosol. And if I were asymptomatic, I might think I'm healthy and okay, but I might be giving out these viral particles, right? And these droplets are emitted in a range of sizes. Remember again, the virus I've blown up. This is not to scale. Virus is 100 nanometers. The droplets typically tend to be larger in size, especially if I'm coughing and sneezing, or even breathing and talking. And I have a distribution of size, right? On the y-axis, vertical axis is the actual concentration. And I've just shown for illustration, I choose a particular size and I might have a certain concentration of these particles. So the virus comes out from an individual, and we want to now understand this. It's a respiratory disease. So it has to sort of enter my respiratory tract. If it's on my skin, most likely it's not going to cause any problem unless I, of course, stick my fingers into my nostril or my mouth. But let's look at the airborne nature of this viral particle. I'm breathing all the time, right? I'm inhaling, I'm exhaling. And these particles, if they happen to be around, or these viruses in those droplets, or if someone is coughing right in front of our face, I might be potentially exposed to this. And this is a certain deposition characteristic. Let's focus on the graph. I'm plotting the deposition efficiency as a function of particle size. And I've split it down into different regions for respiratory tract. The cartoon indicates that. And you might say that the red stuff is a cloud of particles that are being inhaled. And depending on the size, it will either deposit in the upper respiratory tract or the bronchial regions or the alveoli, which are deep in the lung, right? And that is a size-dependent phenomena. And that's why the size is so important. If you notice this cartoon, you see some red stuff also coming out. So when I exhale, I'm actually giving out these particles too. I'm not inhaling, I'm inhaling the whole thing. They're not all depositing in my lungs, but they might be coming out. And obviously, if this individual is infected, they would also give out additional viral particles. So that's what we would try to understand. So key messages, I have a range of particle sizes. Depending on that, I inhale them. Some of them will deposit, some of them will be exhaled out. And there is a size-dependent characteristic that I should be familiar with. Okay, now let's try to understand if I've inhaled some of the cough droplets or viral particles, how is the infection actually caused, right? So let's look at that. The first thing, now remember that spike protein, it is that mushroom-shaped thing. It's going to bind to a lung cell or cells in the lung. The mushroom-shaped spikes will bind to a receptor. This is an enzymatic receptor, and there are a lot of these in our lung. It's called the ACE2 enzyme, right? And these are easily accessible in the lung. And I was talking about evolution. These things, you know, they are sort of living organisms, but then they evolve in a manner to latch on to these cells and to these enzymes. So the shape might have evolved in this manner, and the ACE2 enzyme is prevalent in many different organs in the human system. So that will help it to bind. It might fuse and enter the cell. And once inside the cell, the RNA is released into the nucleus. It tricks the cell into sort of replicating and producing more of this RNA. And the key thing about the SARS-CoV-2 virus is it has a self-correcting mechanism. You know, our cells are also smart. They don't want foreign objects to be multiplying and duplicating. So they might squish the process. But this RNA of the SARS-CoV-2 virus has a self-correcting mechanism. Now, some of this might be a little bit detailed. I'm just glancing through it, but just understand that it tricks the cell to replicate, right? And then it sheds it. So one viral particle enters my lung, produces maybe 10 of them, and I shed it through the mucus, so it's coming back out. Remember, the individual breathing out or sneezing or coughing, those are symptoms. They will be giving out these viruses. And then, of course, an individual happens to be walking around. If they remain infected, if the virus remains, as it's known as virulent, then an individual could inhale it and the cycle continues. So I'm going to just show you some sketches. Again, on the left is that coronavirus, and look at that spike protein and look at the ACE2 receptor. In fact, that mushroom-shaped head fits exactly into this opening for the ACE2 and then enters these lung cells, right? That's the binding process. And then, of course, they enter the human cell, as I indicated. Just continuing, I think I have a nice cartoon here. It'll go by quickly. So the viral particle entered a cell, and the RNA came out. I'll rerun this again, and you can see how the virus multiplies, right? And you can read below, it sheds the protein coat inside the cell. Let's just run it once more and see. Now track it from the left. It enters. The RNA comes loose, enters the nucleus, multiplies, and there's a self-assembling, replicating process. So 1 became 3, and then ultimately the cell sheds these things out. Of course, there are symptoms associated with this. This could be very problematic. I'll let my physician friends address some of the issues about symptoms and problems with lungs. Yeah. You tend to develop pneumonia and things like that. But this just illustrated nicely the replication process through this cartoon that I just talked about. Now, why do we want to even understand this, right? You might be wondering. And of course, you want to feel smart. Next time you see your colleague, especially kids in high school, you can tell them, hey, I know how this virus moves about in the human system. But more importantly, it's not just feeling smart. You want to innovate and come up with prevention strategies, right? The ultimate goal, look at all the people suffering. Even in the United States, more than 85,000 people have died. There's no other endpoint than actually just dying. I want to protect ourselves, so we might want to develop a vaccine. We might want to have antiviral medication. We hear a lot of this. In some sense, we are a little unprepared. We are scrambling. The virus is also a new entity. But all of this is happening now, and a basic understanding will help us do that. And I'll just give you one strategy, right? And there are multiple strategies. So I want to come up with an antiviral, which I will also deliver like an aerosol. I'm inhaling the virus. Let me also inhale my medication. And knowing and understanding the size and those deposition patterns, if I can deposit my medication in the same location, at least there's going to be contact. I have some understanding the spike protein is the first step in attaching and entering the cell. Can I do something to break off the spike protein's functionality, right? Then inside the cell, you saw that replication process. Can I prevent the replication inside the cell? And all of this could happen through just the aerosolized delivery mechanism, right? So we are doing a lot of studies on this. Again, just to give you a quick snapshot as how the basic understanding then helps us advance this. This is, again, a busy slide. It shows you all the different steps. On the left side of the screen is the SARS-CoV-2 virus being trapped in the AC2 enzyme, entering the cell and then splitting out, the RNA entering the nucleus, and on the right-hand side, the RNA replicating. So if I can prevent that, right, if I can even prevent it from entering, that nothing as great as that. And the way to do it is to really affect the spike protein. So that's one strategy. And of course, a whole team of scientists will be developing drugs, antivirals, people will be experimenting. There is nothing like that proven as yet. The race is on for people to come up with a solution. Or I can look at the assembly process, understand the physics of assembly and try to prevent that so that the replication doesn't take place in the cell. So just to give you an example, let's come back to a layperson understanding now on modes of transmission. So if an individual is coughing, sneezing, and even just talking like I'm doing now, or you breathing while you are listening to me, you give out aerosols, right? They are in a range of sizes. Let's say that this individual who you're seeing on your screen was a carrier of the virus. Clearly, some of this is coming out in these droplets that we are breathing out, sneezing out, and so forth. If nothing happens, if no one is around, eventually these droplets will settle down. But before that, if I come into direct contact, and that's why, again, the youth, your parents tell you not to be kissing around and so forth, and even handshakes are now disappearing. So you will recall the namaste coming in, and you see this in social media. It's going to become the norm. Where we come from, the folks were much smarter way earlier on, and they used this form of greeting. So that's a direct contact, right? Obviously, if I'm in direct contact, I'm going to pick up some of these. There is an indirect mode. These droplets which I release into the air will eventually settle down, and it might settle on a surface. Or if the individual is carrying some of this in their hands, they open the door. They might stick to a doorknob till the next person comes and opens the same door. And this is known as a fomite method of transmission. And the third, of course, is the airborne transmission mode, very particular to this virus. I won't talk about the first two, I just mentioned it, but let's look in a little more detail about the airborne transmission. I can again write down equations for transport. I told you we know the size distribution of all these droplets. I can do calculations and determine a lifetime. So I'll just jump to the bottom of the screen. You can see that I can find out how far the droplet will traverse. A larger droplet will settle down faster. They will have a shorter lifetime. They might be carrying a lot more virus particles, but they will settle down faster. A smaller droplet will stay afloat for a longer time so that the chances of someone being exposed are greater. And our calculations indicate, I'll just say it up front, 6 feet, you might have heard this distance is not enough. 12 feet is a much safer distance to stay away from someone, especially if you're going to be hanging around them for a longer time period. So calculations like this are extremely important. Again, a simple thing to say, how far should I be from another individual, right? The next thing I would say is face masks and respirators. You cannot dodge those droplets coming off that someone is giving off, right? Or you cannot distance yourself adequately. Like if I go to a certain location, I'm shopping and another individual comes shopping next to me, maybe I don't keep a distance of 12 feet, right? So, and then also you're listening to my lecture and you understand some of these and you want to stay away. So the solution to that is to use a face mask. There is something called the N95 respirator. And it's a very specially designed respirator, looks very simple. This is being held for the healthcare workers. And you see it has a sort of dumbbell shaped object, right? So if you put your hand in front of your mouth and breathe out, it comes out much further. And if you put it comes out much faster. If you put your hand away, you can barely feel your breath. So this design actually keeps the filtration media away from your mouth and nose, and the velocity becomes much slower. So the mode is a diffusional capture. Again, a lot of details, but just telling you in qualitative terms, it's a very efficient face mask. There's been a shortage in the United States, sometimes unbelievable why we have a shortage of these things, that people are saying, let's hold these for healthcare workers, for physicians who are on the front line. But what do we do, right? When I go shopping, there are surgical or homemade masks. And the message, again, the simple message is, okay, it's not as good as an N95 mask. This sits more tightly in front of my face, but still use it, right? And this mask, you'll be surprised, is more to protect others than even yourself. It's not very efficient when you breathe through it, because some of these small particles will break through. But if you're exhaling, it's going to trap most of it because they come out. There's another mechanism of inertia by which these are captured. So the question is, you're wearing this more to protect others and partially protect yourself. So I look at this nice simple cartoon. On the left is a virus carrier. This individual is infected. On the right is a healthy individual, and neither of them are wearing a mask. So the transmission probability is very high from all that I have told you, right? It's extremely high. Now, if the virus carrier is not wearing a mask, and I am a careful individual, I know that these masks are good to wear. There's some form of protection, and there will be still a high degree. As I said, they're not as efficient. N95 is extremely efficient, but we are keeping that for our healthcare workers. So there will be some transmission, but not as high as the first case, of course, when you don't wear any mask. Then it's best if the virus carrier, the individual, wears a mask, and let's say you're not wearing a mask. There is some transmission probability. It's moderate because some of these particles will still leak out. They float around for a certain time, and there's some chance you will pick it up. But it's much more important that a virus carrier individual wears a mask. Of course, the best thing is for both individuals, every individual, to be wearing a mask, and the transmission probability is the lowest. And this could be a homemade mask. And I know many of you make these masks and use them, especially if you're going out. So the key message here is, anytime you're in an indoor environment with other people, and if you don't know these, like it's not your own family members who you know the situation extremely well, you've got to wear a mask. You're protecting others more importantly, and you are also protecting yourself. And if everyone does it, that's a good public health scenario. I didn't talk about testing, tracing. I mentioned things are reopening now. I, of course, work at the university. Our labs are shut down. The research labs, the graduate students are urging to go back. How do we do that? Of course, a good thing is to test them, constantly test them, but unfortunately, we still don't have a robust, accurate, and a quick test. And you want to trace them, right? So you want to know who these folks are hanging around, because if they turn out to be a positive case, you want to sort of isolate the entire group of people. Obviously, a vaccine is the best way forward. Even that is 12 months away. And some of these we could discuss in the question answer session. Okay, let me just summarize. SARS-CoV-2, it's a nanoparticle to me. I'm a nanoparticle expert, so I like to label them with terminology I'm familiar with. Our common cold virus is also a coronavirus. The regular flu virus is a coronavirus. they only tend to infect the upper respiratory tract. But the SARS-CoV-2 is sort of readily transmitted and very infective in the lower portions of the lung. It's a mutant hybrid. We are still understanding the basics of it, but we really need to be cautious and careful. Obviously, I can lock myself up in home, just like we are now today. I'm giving this talk from my study at home. You want to stay isolated. If you want to go out, you want to be physically distanced. I told you how far. You could actually do calculations for a specific situation. You want to wash your hands often because you might be picking this up from a contaminated surface. If you go, especially if you go to a public place, you want to wear a face mask, even if it's a crude face mask, it's a bandana, it's your t-shirt you wrap around your face. You design your own one. There are good designs. If you look up some of our websites, we can quantitatively tell you which are good designs. The high quality face masks we have to save for our healthcare workers and healthcare professionals. They are in the front line. They absolutely need to be protected. Testing, tracing, and then going back, basic science, basic engineering research, these all remain critical. Okay, with that, I'll sort of pause and thank you for listening. Let's move into our next, maybe our more exciting part of the program, where our 4 physician colleagues will answer some questions. I'll just get them started. Then I'll be turning back to the moderators who have compiled many of your questions, and they are going to ask the panelists to provide answers. So let's just start. I noted Dr. Devapriya De is on. Thank you for coming on. He's a frontline physician and he's actually working. I think he's calling in from work. So we should be privileged that we have him. You've seen many of these patients. Can you briefly describe your experience as you handle?
Sure, absolutely.
Yeah.
Yes, first of all, Pratim, I'll tell you that you did an excellent presentation. You gave a very good synopsis of what the virus is, what it's capable of doing, how the mode of transmission is, because this is so important because prevention is the most important thing that we can do at this stage. You know, once the disease is there, starting from asymptomatic to severe disease, it can present anyway, and it's a really fatal disease to have. You know, the mortality rate is pretty high, and there's a lot of hue and cry about this disease, you know, nowadays, as you can see. So just to kind of brief the audiences about the scope of the disease, you know, based on the CDC and WHO studies, you know, there are global cases is about 4.25 million. So many people have been affected. And again, we actually do not know the prevalence of the disease. This is only patients who have been tested for it. There are many asymptomatic people that are just in the society, you know, that might be asymptomatic, that didn't come forward for testing. So that might be even many more. Just in the United States, you know, there is shortly 1.4 million people that have been tested positive. Out of them, the people who have died from this disease is close to is going to be 84,000 pretty soon. As of yesterday, the number was 83,947. First thing, you know, because I practice hospital medicine, so I see a lot of patients, you know, that I admit from the emergency room. You know, help them, you know, with the diagnosis of the disease, you know, and the treatment part of it. So most important things from the symptom standpoint, you know, the basic symptoms, you know, that this disease presents, you know, in individuals is with high-grade fever. Typically, patients are very fatigued. You know, they feel weak, tired, fatigued, and also they have a dry cough. You know, it's not a moist cough. You know, they don't make much of phlegm. Typically, when you get some of the common cold viruses, you know, that have been there for ages, they typically start having a runny nose, you know, sneezing, you know, coughing, you know, with sometimes, you know, productive sputum. This is a little bit different presentation of this COVID-19 virus. Also, very importantly, I've seen that a lot of patients have been complaining about loss of taste and smell. This is prevalent up to 20% in the patient population, you know, once they have this disease. Throat pain, then the other less common symptoms, you know, include nausea, abdominal pain, vomiting, diarrhea. They occasionally complain of dizziness and headache. Most important, thing that I ask them is, have they been exposed, to anybody that have got diagnosed disease? Then it increases the pre-test probability of the disease. Then you pay more close attention to them. Typically, when patients present to the emergency room, they get a panel of tests done, some blood tests and then some imaging tests. So blood tests typically that we focus on that are pertinent to this disease is a complete blood count, where it sometimes shows lymphopenia. The lymphocytes are predominantly low in this patient subset. Then also some of the inflammatory markers, they are typically high, like C-reactive protein, ferritin, LDH, which is a marker of cell destruction or cell death. And then also we check a chest X-ray. The pattern of chest X-ray that we are interested in is a very diffuse whitish opacification of the lung, mostly in the periphery rather than in the central area. This is opposed to a normal chest X-ray where patients have a bacterial pneumonia. It's a very dense whitish opacification in a particular lung field. So sometimes the chest X-ray it really increases the pretest probability of the disease, if they have a positive exposure or signs and symptoms or the blood tests, that are pretty much in favor of this disease. The most important thing we as physicians, in the hospital pay more focus on is shortness of breath and hypoxia. Hypoxia is, the definition of hypoxia is any oxygen saturation less than 93. We worry when the oxygen saturations become less than 90%, when we check the oxygen by a finger probe. Those are the patients of acute interest. We monitor them in the hospital, monitor their vitals. Fever, we typically take care of them with Tylenol. We give supplemental oxygen therapy. And some patients, they stay stable. Some patients, they kind of deteriorate. In my clinical practice, I've seen a bimodal distribution. Sometimes patients get sick very suddenly. Sometimes I see that patients have been lingering on, with either no oxygen or maybe very minimal requirement, and then maybe day 5, day 6, they suddenly crash. From the treatment standpoint, and actually, just to, pay more focus on the severity of illness, we kind of classify patient into certain subgroups. So, the first subgroup I'll consider as mild. Typically, 81% of the patient population are considered in the milder category, which means that don't have any signs and symptoms of pneumonia, or maybe have pneumonia, but they are not breathless. They are not short of breath. They are not requiring any oxygen. We can just monitor them closely. About 15% of them present with severe disease, that they are either having symptoms of shortness of breath, or they have low oxygen levels, or a chest X-ray that shows very classic disease associated with all these other symptoms. And 5% of them are really in critical shape. They require ventilator support, from the get-go. They require either BiPAP, which is a positive airway pressure, or they have to be intubated with ventilatory support, to decrease the work of their breathing. I pay, focus on particular age groups. Typically, this is a disease that we see more common and more fatal in an elderly population. Starting from 70 to 80 to 90 years of age, I see like 8% mortality. Above 80% in our hospital is about 15% mortality. Typically, a patient who is destined to go on a ventilator, it's a 50-50% chance. We update the patient's family that if they can make it, it's a miracle. If they pass away, unfortunately, that is where they are heading to. And it's very sad to see them, struggle. But that is how the disease is presenting in the hospital setting.
Right.
Patients who have pre-existing disease conditions like cardiovascular disease, they are at 10.5% chance, of decompensation. Diabetes mellitus about 7.3. Chronic respiratory disease like chronic obstructive pulmonary disease in smokers or asthma patients is like 6.3%. Cancer, especially malignant cancers, metastatic cancers, it's like 5.6% of like case fatality rate. Based on the
come back to you. We'll give the other panelists a chance. This is just an introductory round, and there are many questions, so we would like the audience to have a chance. So thanks for those initial comments. Let's move on. The next question is for Shurojit Mojumdar. You're of course, internal medicine specialist. Have you encountered any COVID-19 patients, and how is St. Luke's handling the pandemic? I'll request you to give a brief initial answer. Turn on your video when you speak so the audience can see you.
Thank you. Thank you, Praveen. That was an excellent introduction to the problem of COVID-19. So from our perspective, we have seen two different sides. One is from the outpatient aspect. We did what we could to keep the patients out of trouble. And what we did, we kind of adopted a protocol where when the patient were calling our office with some symptoms of fever, shortness of breath, cough, we told them, okay, go ahead and get the test done. So we send them to our testing center, and they got the test. And out of what we did from the outpatient side, we did about 1,100 tests. And from March 1st up until now, we have had 140 positive cases, but only like maybe 2 to 3% had to go to the hospital. And the presentation was either shortness of breath or fever with cough. And some did develop some chest pain because that was one of the factors that put them in the hospital. And what most of the patients that had minimal symptoms, we reassured them, we told them to stay home and to get medical care when they were feeling more sick. We asked them to monitor their symptoms carefully, like to check their temperature 4 times a day, and then to stay well hydrated by taking plenty of water and drinks.
Request everyone to be on mute. Please put your
to take Tylenol if they were feeling, muscle aches or fatigue, and to make an appointment with the healthcare provider when they were feeling better. And we also advise them to wear face masks if they're coming in contact with their, other family members, and to keep the safe distance, what we call is a physical distancing of minimum. And we also told them that if they are feeling short of breath, or if they had chest pain or new confusion or inability to stay awake, or developing bluish lips or face, they should head to the emergency room. So that was our kind of outpatient side policy that we kind of adopted. There was no specific medicine. Some patients were asking for this hydroxychloroquine, and our hospital took a stand that we were not going to prescribe that medicine because the studies have, did not show any benefit, and there were more risk involved, including cardiac arrhythmia. So we did not, we were not kind of treatment. So that was basically the outpatient side of from our perspective that we adopted.
Thank you, Shurojit. Let's move on to the next question. This sometimes gets stuck. Okay, Dr. Bishan Chakraborty, I described the ACE2 receptors and them being present in the lung and how the virus attaches to it. I think you're a kidney specialist. I know there are a lot of these receptors in the kidney, maybe in the other organs. Could you outline a little bit the impact of the virus to the kidney or any other organs or the potential for that?
Sure. Pratim, firstly, thank you very much for having me. Great initiative. So there is a broad scope to answer for your question, but I will try and keep it streamlined. So firstly, we don't have any causal evidence of any damage on the kidneys by per se at this time. And the answer hypothesized might be related to your to your presentation where you talked about the ACE2 receptors. The expression of ACE2 receptors in the proximal tubule of the kidneys, those are different from how it is expressed in the lungs. And the kidneys, as you know, the various parts of the kidney can be damaged, the wall, the inside of the kidney, and also the vasculature of the kidney. So when the tubules are damaged, the effects are different from when the glomerulus or the wall of the kidney is damaged. So that's why we don't yet have a causal evidence of causal damage. But as you might know, there's a time sequence thing here, like which showed up with HIV or hepatitis, where over time we found that the chronic buildup of the virus in the kidney can manifest. So we don't know if that is the case as of now. But acutely, we are dealing with the virus in various forms, from all stages of kidney disease, or even mild kidney disease, when the type of medications you take can be impacted by the virus. People who have more severe kidney disease, people who are on dialysis, transplants, each is a nuanced variety, and we're trying to cope up with our learning curves here. So if you have time, I can expand on that, but I think that's pretty much how things are at this moment.
Great, thank you so much. Let's go to the last question. That is to Dr. Moiety, if my screen moves on. Sometimes this thing gets stuck. Okay, Dr. Moiety, you're a specialist in neurology. A little that I know, we deal a lot with the respiratory tract, and there are these ion channels that even connect to the brain. So continuing in the same mode, do you think there are impacts of this disease on the neurological system? Anything you could elucidate would be very helpful to us, audience.
Thanks, Pratim. First thing first, that was a great talk and great work that's ongoing in your lab. That's awesome. So you have a couple of parts to your question. One is whether it gets to the brain and how does it do so? And the second part is, does it have any neurologic manifestation? So the short and sweet answer is, for the first part of the question, we don't know really. From our historical experience based on the SARS coronavirus, the predecessor to the two, the one that is currently creating havoc, we know that the previous versions, including the MERS, which was the Middle East coronavirus, did get to the brain. So the assumption is this one will do too, but we don't have much of direct evidence in terms of whether it actually does or not. There have been some postmortem brains that people have looked at, and they didn't at least report any evidence of the virus in the brain, but there was evidence of inflammation and possibly infection. So the hypothesis is it does get to the brain. Now, there was a very recent paper that came out in the last month, and they looked at cerebrospinal fluid, which is the fluid that bathes the brain and then comes down around the spinal cord. And you can go in with a lumbar puncture and get a small part of the fluid and then run some tests to see if the virus is actually there. And this was just one person, so a single case from Japan, where people found that the virus, even though they did not detect the virus in the typical way we diagnose from the nasopharyngeal swabs, they did find evidence of the virus in the CSF, the cerebrospinal fluid. So that tells you it does get to the brain. So this is the only evidence we have, direct evidence in terms of whether it does get to the brain. In terms of how it goes onto the brain, whether it latches onto the S2 receptors, by the way, which are also present in the brain, which are pretty ubiquitous, or if it goes through some other mechanism, we don't know. But it definitely does cause a lot of neurologic manifestations that we are pretty sure about. There's not much uncertainty there. So there are a couple of reasonably sized case series that came out. The first one was from China, from Wuhan, where they looked at around 200 patients, and almost 36% of them had neurologic manifestations. And the most alarming of those, most commonly what people found were they were a little altered in terms of their wakefulness, in terms of how they would respond, if they were more sleepy. But that is expected with any ongoing infection in the body. So I don't know if that is specific to coronavirus. But what they found, what was very alarming, was a significant percentage, almost 6% of the patients who were severely affected, even young individuals, did stroke out. So when I say stroke, what I mean is a part of the brain is deprived of its blood supply and oxygenation, and that part dies out. So typically how that happens is a clot, wherever it forms, either it forms in the brain or it forms somewhere else in the body and can migrate to the brain. It lodges in the small vessel, cuts off the blood supply, the part of the brain dies. Typically we see this in older individuals with a lot of underlying comorbidities. But in the patients with severe coronavirus, almost 6% of this population, even younger individuals, had strokes. What we still don't understand is whether it was a direct effect of the significant clotting that is ongoing in the body during coronavirus infection, which we have already noticed, or whether it's an inflammation and the brain vessels are more sensitive and they somehow form the clot there and the part of the brain strokes out. We don't know. So the mechanism is still not clear, but we definitely see quite a few neurologic manifestations.
Great. So thank you. Yeah. So people realize that this is an extremely complex disease. The audience, thank you very much for sending in your questions. I will be turning over to our moderators who will read the question and address it to the panelists. So if the moderators could come back on and go through the questions. And please, the others, if you want to ask some questions, type it in the chat section. And we will monitor that, and time permitting, we will also address those. We hope to address those too. So moderators, please take over. Maybe I'll also stop. So either Shirin or Ankita, one of you could start with the questions to the panelists. Can you hear me? Yeah?
Yes. Thank you, Dr. Vishwas, Dr. De, Dr. Mojumdar, and Dr. Chakravarti and Dr. Maiti for the nice presentation. Now for our first question, it is to Dr. Chakravarti. What are some of the symptoms and complications that COVID-19 can cause?
Okay. So symptoms would be what a patient or a person feels, right? And signs would be what manifests in the body of the patient, right? When you look at it clinically. So in terms of symptoms, as we all know, it's all over the newspapers, all over CDC and WHO guidelines. The top 3 or 4 symptoms that you really need to look out for is a fever. And when I last checked in the public, it was 100.4. And then you have a sore throat, which was added recently. You have a cough, a dry cough, and it was postulated to be dry because of where it was attacking the airway. But I think that has now smeared into all directions. So any kind of a cough, you should be in a high suspicion and get yourself, call your primary care doctor, go to the hospital, call the local helplines and find out more. Other symptoms which you must have heard of include loss of smell and taste. And also one of the rare peculiar symptoms which have shown up is called the COVID toe. I don't know if you looked at that as a COVID toe in the hospital, but I have not seen it, but I've heard of that too. I think in short, these would be the initial symptoms, but you can look up COVID toe too. I'm sure we haven't seen it in everyday life, but in the hospitals, people have seen some weird manifestation related to blood clotting called COVID-2.
Okay, thank you. If someone has recovered from COVID-19, are they immune to it?
It's $1 million question, right? Is that for me or for someone else?
For you still.
Me still? Okay. It's not easy to put it out and say yes and no at this time. Okay. The reason for that would be, I don't know, a lot of the audience would remember how we had chicken pox growing up in India. But there was always a fear, a scare that it can re-manifest later on in life. So viruses present in different way, how the virus is shed, what kind of antibodies develop, how they develop over time, and the trends of these antibodies decide a lot of how reactivation or latency works out. So I would say at this time, we don't have an answer to that. I'm sorry.
Next question, is herd immunity or vaccination better?
I think it's not and or. I think it's the way to look at it would be and, where you need herd immunity and vaccination for any disease that's prevalent like this, or any disease that is spread via any kind of infectious manifestations. So I think you need to look at both herd immunity. If that can be achieved, a lot of health policy and government policies are looking at that, and I don't think they're finding an easy answer to that. As for vaccination, you can read up on the various other vaccines that have come up for other diseases and how successful they are, and you'll see that yes, a lot of diseases in the last 50 years, the way we've approached them with vaccines has been successful in eradicating them.
Do people that have developed
just a second, I would request the moderators to read all the questions to an individual because of the time constraint. So just read all, if there are multiple questions, read all of them at one shot, and then they'll answer. Thank you so much. Yeah, go ahead.
Do people that have developed herd immunity still need a vaccination? And how successful is plasma therapy or ionized plasma therapy?
So first part of your question, do people who have, got vaccination also, what was the question again, sorry?
Do people that have developed herd immunity still need a vaccination?
Herd immunity is a concept where a certain percentage of people get the virus, and then they don't need to be treated for it. So at this time, there's no plan to get people, once you develop that kind of a prevalence of disease, you don't need a vaccine for those people. But the remainder fraction of the people, they might need to be considered for vaccination. What was the second part of your question?
How successful is plasma therapy or ionized plasma therapy?
In my clinical practice, I've not seen it work. In the literature that we've reviewed, yes, there is a potential for it to be, postulated for use, because the kind of principle that is used in plasma therapy or ionized plasma therapy is used for a lot of diseases that attack the immune system. So, that kind of treatment right now at this time, there's no sure shot, yes, that you need it for a certain indication that has not yet been proven as such.
Thank you.
Mm-hmm.
Thank you, Dr. Chakraborty. Our next set of questions is for Dr. Majumdar. So why are individuals over 60 at a greater risk for getting infected, regardless of their prevailing health conditions? And what is your advice for older people as lockdown ends? What does the category of compromised immune system entail, and why are they at a greater risk for getting COVID-19?
So to answer your first question, people over 60 because their immune system kind of falters and slowly declines as we get older, our immune system is very robust when we are in our teenage and when you are in our 20s or 30s, but then it starts to decline. That's a natural aging process. So once we are above the age of 60 and we have comorbid conditions like hypertension, diabetes, heart failure, COPD, which is the chronic obstructive pulmonary disease, or even asthma, they are considered that those people react to the virus differently. Like they get more sick because the virus gets an overwhelming effect on their body. And even in some patients that we are seeing now, especially in kids, this new concept of Kawasaki disease, which is an inflammation, although the children under 5 years of age used to have Kawasaki disease, now the COVID-19 is causing a syndrome they're calling COVID-19 related Kawasaki disease, where there is inflammation of the medium-sized vessels in their body. And they're developing a rash, they're developing, all kinds of other problems like swelling of glands, and they're getting, they're recovering with treatment because their antibodies positive. So we are seeing a peculiar phenomenon of these symptoms and signs of Kawasaki disease in a little bit older children. And so this virus is presenting in different ways. And people that have hypertension or older patients like 70, 75 plus, their immune system cannot fight the virus. And sometimes the immune system itself is actually causing more harm than good. So your immune system releases, when it's trying to fight the virus, it releases something called inflammatory cytokines. So there is a cytokine storm that is so overwhelming, it's causing like the lungs to fail and the people are getting sicker. And sometimes that is the cause of the detrimental outcome of the patient. So people are getting intubated, going to the ICU because of their cytokine storm. So they're trying to help those patients with certain treatment that blocks those cytokine storm. When there is inflammatory markers, they are checking and they're finding that the patient's CRP or the inflammatory markers are very high. They're trying to treat those with anti-inflammatory medications. And then they're seeing some response in certain number of patients. And what was the second part of the question? What was the other part of the question?
You answered most of it except what is your advice for older people as lockdown ends?
So what we tell our patients, if they're above 65, to stay home and follow the hand washing precautions, like wash your hands for 20 seconds, wear a mask. If you're going to a crowded place or like to a grocery store, always wear a mask. And when wipe if they're using a cart, if they can get a Purell, some of the stores are using soap and water to wash their hands and clean the carts and take it to the grocery store. And when they're coming home, also to wash their hands and not to touch their face or nose or eyes when they're out. And when they come home, even cleaning the fruits and vegetables that they've bought in clean water for several minutes, just to minimize the viral load if they're exposed. And that's basically, we are telling the patients to stay home. If they have any symptoms that they have a cough or shortness of breath, we are testing them, but mostly we are telling them to stay home and not to go out and to maintain physical distancing, even with their relatives or other members of the family.
Thank you so much, Dr. Majumdar.
Thank you.
Our next question is for Dr. De. What are the key lessons or observations you've learned from being at the front line? What are some infection control options within hospitals and for healthcare workers? Is it safe to get care for other medical conditions during this time?
So Dr. Day is actually working in the hospital. Maybe he has been called off
Okay.
Maybe you could go to the next question, to the next panelist.
Then
Okay. So our next set of questions is for Dr. Maiti. Can the virus be spread through food, including restaurant takeout, refrigerated or frozen packaged foods? What temperature kills the virus that causes COVID-19? And what is routine cleaning, and how frequently should facilities be cleaned to reduce the potential spread of the disease?
Great question. But there is no real right or wrong answer to that. We don't have much of data. In terms of the virus surviving on contaminated objects, it depends on a lot of things. It depends on how much viral load there was, how when it got infected, how much of the virus was deposited on the surface, and what is the kind of environment it is exposed to. Is it in a really hot and humid place, or is it in the cold out in the open? The virus, when it is outside the host, cannot multiply. So it is just counting days where it has to find a host to get in. And there are several studies which have kind of given a range in terms of how long the virus can survive. And typically it ranges from 6 to 9 days was the experience with the previous version of the virus. This virus, I'm seeing numbers from 4 to 7 days. We don't know what to trust as yet because the data is limited at this time. So whenever you get food, restaurant food takeout, the ideal thing to do would be to discard the plastic containers, just transfer the food to something else, and then just discard the containers, wash your hand, and then go move on. In terms of cleaning the household utensils and surfaces, it is as much as is possible. You don't have to do it several times every day, but at least once a day at the end, if you clean up the surface, or if you think there is a possibility of something that is contaminated, like you got something from the store and you kept it somewhere, then it's reasonable to clean that place up. Just the common sense thing. There is no right or wrong answer to this. Keep your antennae up and respond as appropriate.
Thank you so much, Dr. Maiti, for chocolate.
Are you done with your list? Maybe I'll pull one from the chat session. There was a question about, I think parents ask this question a lot who have college going children or maybe even high school going children. What about how will a college reopen? How will you take care of students who would probably go to a cafeteria to have their lunch? Do you think that opening of colleges is even possible? This again, like everything else, I think I'll try to answer it being at a university and on my front line. This is like everything else with COVID-19, the uncertainty sort of dominates. And we go through these scenario tests, and we are going through it even at Washington University and practically any university, at least in the United States. But they are really preparing. I mentioned testing. While tests may not be approved by the FDA, there are some homegrown tests by colleagues in the School of Medicine. And this will be done very rapidly. Not only would we reopen, but we are also thinking of bringing our students into a dormitory setting. And you can see the challenges associated with that. So if there is routine testing done, like literally multiple times in a week, and if we are tracking, tracing the people they're hanging out with and keeping a certain locality as a quarantine locality, because our university students come from all over the world. You can't just send them home instantaneously. So quarantining them locally is something that is being explored. The university will become like a fenced entity. So even I, who is traveling from home as a professor, will be tested anytime I enter the university campus, and maybe even when I leave. And it, of course, becomes a big data problem, a data analytics problem. So you see, even our IT colleagues here in the audience, there's a role for all of you to play and be innovative in things you want to do. So there is a lot of discussion going, though I'll take the other side. California universities have already made the call that they will not be opening, that everything will be online. But you know, some of the leading universities thrive on this person-to-person educational experience, and it's going to be rather restricted. But on the other hand, with distancing, with testing, tracing, we will continue this. Okay. Good. Are there other questions that the moderators had, or are you all done? I presume
Yes.
there are some more in the chat. Maybe I ask the panelists, how long is the virus viable in air? And are there breathing exercises for individuals that you would like to recommend? Any of the panelists can take it and answer. I'll open it up. So are any breathing exercises of value, and how long is the virus viable in the air? Yeah.
I think once the virus, as you explained, Pratim, the virus depends on the particle size. If the particle size is very small, it can float for about 8 minutes. If the particle size is big, it drops to the bottom of the floor. And if it drops on plastic or metal object, it can survive for up to 72 hours. So that's why doorknobs and metal surfaces, and what we are doing is every day we are telling our patients and our staff to clean even the computer keyboards and whatever they're touching on a day-to-day basis, to clean with a Purell or sanitized wipes. It has to have an alcohol percentage of 70%, or you can even make a homemade, like 5 teaspoons of bleach in a gallon of water is a good disinfectant. So you can clean the surfaces that you are coming in, constant contact once a day, or so to minimize the chance of the virus to spread. And for other contact surfaces like copper has only 4 hours of viability. The virus only lives for 4 hours. And if it drops on a cardboard piece or even a brown paper bag, it can still survive for 24 hours, as you probably know that. So that's what we think, that if you maintain that sort of cleaning procedures, hand washing, then you're probably following the safety measures. As for your second part of the question, which is, could you repeat the second part of the question?
The second part is, are there any breathing exercises that you would recommend for individuals?
So no definite breathing exercise, but we do recommend doing even regular freehand exercise, because that will expand the lung, the bottom part of the lungs in patients that have respiratory disorders. They take shallow breaths. So the bottom part of the lungs do not expand fully, and they have a tendency to develop what we call is atelectasis. And if they're just resting in the, lying down in the bed and not moving around, not doing any exercise, they have a higher tendency to develop these atelectatic part of the lung. And that can, predispose them to catch this or get more complications. So if they have, say, asthma, even if they're using their medicines or the inhalers, they should continue to do that. And they should do exercise on a regular basis. There is no particular breathing exercise that has developed to minimize the complications per se.
Great, thank you. Dr. Chakrabarti, Bishan Chakrabarti, one of the audience members is asking, could you specifically say, is there a concern or risk to teenagers? Is it low, is it high? What do you think to teenagers? Yeah.
So if you want to quantify risk, I think we'll have to look at risk factors. So the risk factors, that is the clearest risk factor that has been delineated till now is age. And along with age, you pick up the chronic diseases of life, diabetes, hypertension, and then those have also been, they have an attributable risk to this condition. Now, as another panelist talked about, there's a new finding of an inflammatory condition that is being manifested in this disease, where the blood vessels, the small blood vessels, are also getting inflamed. Now, that is being seen more in children. I don't know if that is even can be transferred across to the teenagers, but I don't think there's any clear data that I've looked at which talks of teenagers per se. I would go anecdotally and say that in the last few months, we've seen how the restrictions and social distancing, that was a bit of a concern initially with our younger populations. I think they should lead the way and also follow any of the guidelines that the government is giving to us, and go ahead with that. As for risk for teenagers, I don't think I've come across anything specifically.
I just want to say something that under the age of 18, there is more, as you mentioned, this called COVID toe. It's actually, the other name for it is called Pernio, P-E-R-N-I-O, that's how it's spelled. They don't need any treatment, and they are developing in younger kids. They can cause a burning sensation around the toenails, and there's a redness and slightly raised type of lesions that are developing, which looks like a rash, like a little reddish purplish rash. And younger teenagers are developing that. They don't have any other symptoms, and that's why they're called COVID toes. And they're going away on its own without any treatment. 2 to 3 weeks time is the time frame the pediatricians have seen for these COVID toes. And they're happening more in teenagers. So I just wanted to throw that.
Great. So Dr. Maiti, I'll ask you the next question. Someone is asking, do you think there is going to be a home test for the virus, just like we have a blood pressure measurement test or a sugar test, a blood sugar test? Do you think we would have a test that we can do at home?
So great question. There are many ways to test the virus. Right now, what we are most commonly doing is extracting the genetic material of the virus, the RNA, and just amplifying it and seeing if we have a copy number there, if the virus was ever present there. There are other forms of tests which we commonly use for other kinds of viruses, like the flu viruses, which are the direct antigen tests. But for this one, those have not been tested. Remember, everything had to be pushed through, and what we are right now doing is only the RT-PCR testing. So I don't see that RT-PCR reaction happening at home. What I see is you collecting the sample and mailing it out and somebody running the test for you. So that is very feasible.
Great, thank you. There was another question. It might be more a social science question. I am above the age of 60, but when I go shopping, I don't see others wearing a mask other than myself wearing an N95 mask. Is there anything else to do? I mean, of course, the best is to stay as far away as possible from them. Public education is extremely important. We are all in this together. So whenever you can, I think, re-emphasize even to your friends, colleagues, that wearing a mask is critically important. We do see even on the TV with reopening, people going to a bar, sitting down, not wearing masks, mingling. And of course, the risk is extremely high then. Other than that, there's not much to say. Okay, so that's a quick answer. My question now to the panelists, it's a little specific. My mother suffers from lupus nephritis and takes immunosuppressive drugs. Is she at a higher risk for contracting any infections like or the disease like COVID-19? So individuals who take immunosuppressive drugs. Maybe Shurojit, you want to try?
Yeah, I think taking immunosuppressive drugs like prednisone, or if they have lupus, sometimes they're on methotrexate, or some are on plaquenil, which is the hydroxychloroquine. But in per se, uh, having lupus nephritis, if they're on chronic steroid or steroid sparing, um, uh, like Cellcept, I think one of the nephrologists would know that some lupus nephritis patient would require those type of immunosuppressants. That puts them not for catching the virus easily, but developing complications is a little bit at a higher risk. I would say maybe 17 to 20% higher risk for developing complications. Otherwise, not like catching the virus. If you still follow the precautionary measures, you're still comparable to another person that doesn't have the comorbidities. So that's what my impression.
Okay.
Because we have a lot of rheumatology patients in our practice, and we tell them the same thing: follow the precautions. You're not at a higher risk for getting it easy, but if you get it, you might be sicker than another person that doesn't have, or that are not on those kind of medicines.
Okay, another question is, do similar viruses have a statistical lifespan before which it begins to decline? If so, can we expect natural decline sometime soon? Would Dr. Chakrabarti try to answer? So the question is, will this naturally decline eventually?
I think the question is pointing, from what I'm understanding, towards if we won't see a seasonal spread, or if we're going to see the incidence of the virus dropping. At this time, I don't think it's very early at this time to say if it's going to take a trend in that direction. We've just started opening up the country. Let's see. The social distancing seems to have worked, as you may have followed. But once we open up the country, fingers crossed after that. I don't know how. We might have a few spikes in pockets in which we might have to contain, just like you said. We might have to normatize a lot of our social activities. And like the predictions are more towards a spike in pockets rather than a smear spread. So will it die down completely? The answer is out in the open. But yes, we definitely have seen this social distancing measures that we took for the last couple of months have helped.
Okay, good. Thank you. Dr. Mighty, question to you maybe. What are the risks for air travel, both domestically and internationally? What precautions should airlines take, and what precautions should passengers take? It's more a general, yeah.
Yeah, great question. Not in my wheelhouse, but I'll take a stab at it. So, the real answer is follow the guidelines. But if you can avoid an air travel at this moment, that would be the ideal thing to do. And if you can drive to a place, drive. But in terms of safe air travel, I don't know how feasible it is to maintain the distance as we discuss the droplet spread, the larger droplets and the smaller tiny particles, which are airborne, which survive longer. And there are some studies showing they can last up to 3 hours. So we don't know really the answer here. We don't know how safe it is to travel in an airplane, and especially if it's a long flight. And most of us, we are very inclined to take a long flight back home sometime in the near future, and we don't really know when it'll happen and when it'll be safe to do so. And the precautions in terms of what the airlines can take, I'm pretty sure they'll take everything they can, but it's not in my wheelhouse, and I'm not sure what exactly those would be and how they can sanitize the air that is circulating in the flight for a long time. I'm not sure how to do that. Maybe Pratimda, you can throw some light on it.
Right. So it is, to me, it's like another indoor environment, but of course your trapped in there. So the same guidelines should hold. You try to stay as far away from another individual. You wear a mask, maybe a higher quality mask. Some airlines are requiring passengers to do that. Some are not. And I think that would be wrong. The question is, if we have an alternate, someone might ask, is driving better? Yes, being in your own car is definitely better. But there's also a risk. If it's a long distance drive, you increase the risk of an accident, getting tired. You might have to stop overnight at a place and things like that. So yeah, these are just, again, some general guidelines. Airlines do have a good ventilation system, better than what we have at home. Of course, the pilot has the best quality of air. The first class cabin has a little better than the economy class. So again, these are all certain details. Hopefully they could use some technologies to maybe clean the air more frequently in a flight, right? So let's go to a next question. I have read it might take from 6 months to 18 months to come up with a vaccine. Why is there such an uncertain time period from the scientific community? Is it mainly because of how long it takes to get FDA approval, or something else? Shurajit, you want to try?
Well, all vaccines has to go through first animal testing. Then when you go to the, if you move forward from animal testing, if that's successful, then you go to the human testing, which takes 3 phases. Phase 1, which involves 3 different, sometimes dose strengths. You try the low dose, medium dose, and then high dose to see which dose works better. And then you go to the efficacy, that is usually the second phase 2. And then you go to the phase 3, which involves more number of patients to see whether the vaccine is effective or not. And then you apply to the FDA for if the vaccine works. So it takes a long time from moving from the animal testing to the 3 phases of the human trials to make sure. And then you might, most of the times you'll see that the vaccine failed because you developed a side effect or the vaccine didn't work. So it's a long, but in this case, there are 6 vaccines that are now in human trials, and that skipped the total animal, the process of doing trials on the animals, because they are using testing. What they're doing is they tried to go to the mRNA, like the Moderna's vaccine, went straight to the human trials, and they're using, they named the vaccine M1273, as far as I remember, and they already finished the phase 1 trial. FDA gave emergency authorization to go to phase 2 trial that they're doing, they're just starting that. So there may be a hope that if the vaccine works, and they already went through the 3 different doses, they will pick, after 28 days of the first phase trial, they will pick which dose works best. And then once the phase 2 is done, then they will move on to phase 3, involving more number of patients. So there is a small, hope that maybe early next year, if this vaccine works, we might have a successful vaccine. Oxford University is also doing a trial. The company called Sorrento Pharmaceuticals just came out with an antibody that was 100% successful in neutralizing this virus. So they are starting their trial from July. And then Stanford University, there's 2 infectious disease doctors, both are Indians, and they're infectious disease specialists. They're using interferon lambda as an outpatient, and this interferon lambda is, they're doing the study on 120 patients, double-blinded, and if they see that this interferon alpha lambda works, then that can be used for milder symptom patients as an outpatient. So that's for the treatment part, not as a vaccine part. And that will also be helpful if this works. So there's some hope that something, there are 121 vaccines in trial now.
Great. Yeah, good. So I think there are no other questions. Someone else indicated the virus might mutate, and would the vaccine then work after a year? Would anyone else want to address that? Dr. Maiti or Chakrabarti?
Yes, so there's a strong possibility that the virus will mutate. The RNA viruses do typically do that. And usually our infectious disease specialists, they're up to speed with it, and they tweak the vaccine accordingly. But everything is new and uncharted territory for us right now for the coronavirus. We don't know how fast those things will happen, and because this virus and when it will come back in a different form or fashion, we don't know. So a lot of unknowns up in the air.
Great.
And even in terms of the vaccine, there's so many variables, so many confounders. Just getting a vaccine out in the open, which can generate an antibody, it may not be good enough. We still don't know whether it's the infection or the inflammation, which is causing more hurt and more damage. There are lots of unknowns out here, and
Good.
it'll take some time to get those things straightened out.
Right. Great. Yeah. Thank you. I think we've run out of questions, and our time is also coming to an end here. I would like to thank first our moderators, Shirin Shaha and Ankita Gupta. Thank you so much for setting up this entire event, introducing the speakers, panelists, and also asking questions, collecting questions from the community and asking the panelists. Thank you so much for doing this. I'll also take this opportunity to thank our wonderful panelists, extremely talented group. And you can reach out to them, I'm sure, for more detailed information. Dr. Maiti, Dr. Chakrabarti, Dr. Devapriya De, and Dr. Shurojit Mojumdar. Thank you so much. And with that, I must also thank the audience for listening in at the peak. We have a peak audience also. I think we touched 58 individuals. Thank you for listening in. Hopefully it was of some interest, and do stay safe. I would also say stay sane as you're isolated, and definitely stay healthy. Thank you, everyone. And I would also thank Punascha for organizing this fabulous event. And with that, we will end. And thank you, everybody. Good evening.
Thank you. Thank you,
Thank you,
Pradeep.
Pratima.
Thank you so much.
Yeah. Bye.
Thank you so
Thank
much.
you, Shirin. Thank you, Ankita.
Thank you.